Thanks very much. It's a great pleasure to be here, and it's, I think, just a remarkable tribute that pediatric ethics is thriving here, and it's really exciting to see a program really launched and really doing very, very well. I'm going to be talking about listing decisions for developmentally impaired kids. This is another source of conflict potentially between parents and the teams. All the kinds of cases that we've been talking about and the potential futility issues that we were hearing about earlier sort of take on another added dimension of complexity when you add in the potential of organ transplantation. During the course of depositions in the Shivo case, Terry Shivo's parents were the Schindlers were asked whether or not if she required a heart transplant, whether they would proceed and go forward with something like that. And they responded in the affirmative, that even if she required a heart transplant, that's something that they would want for her. So I think that's something that adds a layer to a lot of the discussion that you've already heard. I want to make it clear that in what I'm talking about here, it's going to be about listing decisions for cadaveric organs. So there's a whole other issue that arises when you've got parents who are willing to make live donation for their kids. I'm not going to talk about that. Lainey Friedman-Ross is actually going to be talking about that in a little bit in one of the breakout sessions. The basis for this talk really came out of a number of consults that we had at Packard Children's Hospital and some really difficult issues. And at one point, the liver team really coming forward and saying, so what do? We have these cases, these tough calls. How do we solve them? And our renal teams also were saying, we've got some ideas. And one of the first things we did was try and find out, what are the guidelines? What's out there? Do you have any information? Are there standards in the profession? And we heard a lot of different sort of informal things. The renal teams mentioned this informal idea that if the kids can feed themselves or progress to feeding themselves, then you list. If they don't, then they won't. But it didn't look like it was codified in any systematic way. So we really started to try and look at this issue. And one of the things that makes it complicated is the incredible broad range of possible cases that we're really talking about, covering anything from baby K and anencephalics or permanently unconscious patients to patients who are profoundly impaired, no mobility, no measurable IQ, to patients who are potentially mildly impaired and have a high level of functioning and are capable of communicating or even attending school. So there's a very broad range of cases that might fall into this category and where you might potentially have conflicts. So one of the first questions we ask is, what happens in practice? Do these kids get listed, and if so, when and how? And we wanted to look and see whether there was any data available. Well, there's some. There's Levinson and Olbrich have an article, and the reference is in your packets, that was published in the 90s that didn't really focus on pediatric patients, but talked about impaired patients more generally. Most of them were adults in that particular study, but gave some indication that, in fact, quite often patients who are impaired or suffering from mental retardation are routinely excluded from transplant, and what their study found was that things were all over the map, that programs weren't consistent, and that there was differences between programs and between organ systems. We wanted to see whether or not those data, which were from the 90s, were still true, and especially what happens when you look at that in a pediatric population. So our group did a study. I'm not going to go into the results of that in a lot of detail. This is something that we're about to submit for publication. But Chris Richards, my medical student, and a number of us did a study of the most active pediatric kidney, liver, and heart transplant programs in the U.S. We surveyed essentially the listed contact persons, the medical directors, surgical director, or transplant coordinators from those programs. It was a total of 88 programs at 45 hospitals surveyed. We got 50 responses, or 57% of the programs. Now again, there's a lot of limitations to this survey. It's a relatively small number. We don't know for sure that the responses we got really correspond to their actual practices, but the results nonetheless were pretty striking. We asked how often neurodevelopmental status is considered in transplant listing decisions, and you can see that it's actually quite often used as a factor in listing decisions. Always 33% of the time, usually 11% of the time. So 44% of the time, neurodevelopmental status is always or usually taken into account, but at the same time, 39% of the time, never or rarely. So there's not at all any kind of agreement within the field about what should be done about this, and that means that kids who are likely to be transplanted in one program will be excluded in another, so that there's going to be a lot of variation across the country with the resulting inequality for patients just depending on what program they happen to go into. Interestingly, given how many programs do use neurodevelopmental status as part of the grounds for their decisions, on the whole, the basis of that decision-making process actually tends to skew towards the informal. When we were asked how formal their standard was on a scale of 1 to 5, you can see that 50% of the programs identified a relatively informal process. 0% thought that they had a very formal process for assessment of neurodevelopmental status. Only 4% even gave a 4 to that answer. So this is something that's clearly taken into account, also being done on a fairly informal basis. The percent of programs that consider neurodevelopmental delay by itself a relative contraindication to listing, and at what degree of delay, you can see here. And although it's a relatively small number, even mild to moderate delay is sometimes used as an exclusionary criteria in at least some cases. So these are patients who presumably are fairly functional, and yet this is a relative contraindication for transplant in some cases. Fairly common at severe, and then profound delay also significantly taken into account some of the times, although there are some programs that say it's completely irrelevant. So again, you can see an incredible array of variation. And the percent of programs that consider neurodevelopmental delay by itself an absolute contraindication. So that is, having this developmental status means that they would automatically be excluded regardless of any other considerations for transplant. And again, you can see there's at least some programs that would exclude even moderately developmentally delayed children and severe, and so everything sort of shifts to the right from the previous slide. But again, a lot of variation from at least some cases where moderately delayed kids are going to be excluded to other programs where they would never use such a criteria in such a way. So a lot of variation. Some other findings in our data: 38% of programs said they had rejected a patient that would have been listed for transplantation had it not been for the patient's neurodevelopmental status. So clearly this is something being taken into account, and on the basis of this, there are kids who are not getting listed because of that. In addition, we gave some hypothetical scenarios, and the response to those scenarios further reflect the fact that teams would sometimes refuse to list patients based on cognitive status, even in cases of mild to moderate delay. We gave a hypothetical scenario that I'll give a version of in a little bit, and 25% of programs said that they would exclude a child with mild to moderate delay when it was concretized in a case example. And our findings are in fact consistent with the Levinson and Ulbrich data, both in terms of the fact that things are all over the map, that there are programs that exclude at surprisingly functional levels, and we actually also found our data fairly similar in terms of the fact that there was a lot of differences between the organ systems, with kidney programs most likely to list such kids and heart programs least likely to list such kids. This also is consistent with the findings of a less formal study done by the National Working Group on Transplantation and Disability, which had an open-ended survey of families and patients and concluded in a paper called Running the Transplant Gauntlet that in fact patients with these conditions often have a great deal of difficulty being able to be listed for transplant. Now, one question that raises from this is why? Why are programs not listing these kids? And there are a number of possible legitimate reasons that might be given. For example, there might very well be that neurodevelopmental status could either be highly correlated or used as a marker for other kind of comorbidities that would give a good medical reason for not listing somebody because of potential for graft failure. Also, there are adherence problems that teams might be concerned about, and again, neurodevelopmental status might be relevant to taking that into account as, again, a reason not to list somebody, not directly on the grounds that they're impaired, but on the grounds that they're being excluded for reasons that the transplant will likely not go as well. And then finally, there's also the possibility that they're not being listed because of some of the considerations that we've already heard today, that there's a sense that the patients may not benefit from it at all, at least in the case of permanently unconscious patients, or that the burdens of the treatment may outweigh the benefits when you take the neurodevelopmental status into account. Now, for those first two reasons, the medical reasons, that maybe it's correlated with poor results or adherence problems, which means that we're probably going to get worse results if we transplant this population, that sort of asks the question, is there data to support those kinds of claims? And in fact, there is some, but not very much. Stephen Reese at Ohio State and his group recently published a paper in which they surveyed the results of all the existing literature on this subject. Is there evidence that neurodevelopmentally delayed or impaired, cognitively impaired kids are in fact likely to have poor outcomes? There are not very many studies that have been conducted, and you can see there's only a handful here. And they all involve extremely small numbers. And these are all kidney transplants of mentally retarded patients. When you combine the data from all of these studies collectively, you actually get results that are fairly consistent with results for healthy children. So 1-year survival rates of 100% and 3-year survival rates of better than 90%. But that's of course very, very limited data. These are all very, very small numbers, and there may be selection bias in the which ones are presented. But it's clear that if the medical facts are the reasons why these kids are not going to be listed, it seems incumbent that we need to have more and better data to justify using that as a basis for excluding some of these kids. Let me make some of this a little more concrete by talking about some of the kinds of cases that we came and that we grappled with for figuring out how we're going to draw a line in these kinds of cases. Let me start with case number 1. This is a 10-year-old boy with Alagille syndrome. He's suffering from liver failure. He's got problems with multiple organ systems, abnormal growth factors. As a very small child or an infant, he had a fall that resulted in an intracranial hemorrhage that produced a profound neurodevelopmental delay. The patient's mother is generally knowledgeable and has been trying very hard to have her son listed for transplant. She's so far gone to 3 centers and been declined at each of them before coming to us. She's hoping both to prolong the patient's life, though because of his condition, his life expectancy is going to be greatly curtailed, and at best case scenario, he might have another decade of life. She also, as much as she wants to extend his life, she's equally concerned about his quality of life and really wants the transplant partly for palliative reasons. He's suffering from pruritus, so he's itching a lot, and so she wants this to partly improve his life. Prior development reports indicate that he's a wheelchair-bound quadriplegic with severe mental retardation and no assignable IQ. The parent, in her description of the child, says that he recognizes family, that he requests action through eye gaze and verbalizes. However, over time, our developmental specialist observed the patient during a 6-week period, both in and outpatient basis, and also requested that a videotape be made of him at home by the mother that captures some of these behaviors, the requests for actions, greeting, etc., that she says that she saw. And so she videotaped these things and said, yeah, these are examples of him greeting and interacting with us. The findings of the developmental assessment was that there was no differentiation at all in reference to communicative intent. There's no responsive facial expressions, no change in behavior, no recognition, no greeting, no negation. These results were reported to the parent, and she actually our developmental specialist went through the video with the parent, and it was very sad when you talked to her. She would ask, the child would just sit and rock back and forth often, and she would then ask yes or no questions and interpret his rocking as yes, even though there was absolutely no change in the motion in response to the kinds of questions that she was asking. And so she had an opportunity to sort of see what he, in some sense, he was really like, and actually I think that was revelatory for her. But so that's case number 1. I would also just add a couple of other factors about this. Multiple organ system problems definitely mean medically the course of transplant would be complicated, and it may very well be that there are some programs that wouldn't list even a cognitively intact patient with this condition. But it is the case that patients with this condition are often listed for transplant in many programs, and the team said they probably would have listed this patient if not for the intracranial hemorrhage and the secondary developmental delay that resulted. So again, the question is, should this child be listed for a liver? Case number 2, a 10-year-old girl with Wolff-Hirschhorn syndrome. Again, profound retardation. I think early on, not clear that she even had a measurable IQ prior to dialysis. Seizures, poor muscle development, wheelchair-bound patient with end-stage renal disease. The parents wanted dialysis initially and wanted consideration of the child for a transplant. Again, parent interview. Parents say the child recognizes family, requests action and objects through expressions, gestures, and vocalizations. Infrequent direct eye contact, but contact through mirrored reflection can be obtained. During the course of a 3-month period, initially inpatient and then in the clinic visit, and continued observation as dialysis was given took place, and found that in fact there was demonstrated differentiation of communicative intent, greeting, negation, preference for parents, request for action, reciprocal activities. There's games that could be designed for the child. So there was a degree of interaction and the ability to communicate and meaningfully interact with the parents. The findings were reported to the parents. So again, should we do dialysis for this patient? Should we list this patient for a transplant? Now let me just add case number 3, which is more of a hypothetical. This is a case that we used in our survey. A 13-year-old boy with alpha-1 antitrypsin deficiency. We had obviously modified versions for heart and for kidney cases. The child's liver is clearly starting to malfunction, requiring transplant. The patient has no other complications that would be contraindications. But the patient also has Fragile X syndrome and an IQ of 50. The patient lives at a group home, and although attending school part-time, is at a 2nd grade level and will likely not progress beyond that point. The child's legal guardians now are looking to the physicians to make decisions about continuing medical treatment and perhaps listing this patient as a transplant candidate. And again, when we gave this as a hypothetical result to these programs and comparable cases for the other organ systems, about 25% said that they would not list this child. So this is obviously a much higher functioning child who many would not list under these circumstances. So when we talked about this first among ourselves within the ethics committee and a subcommittee that was charged with dealing with this kind of case, and then later in a consensus conference that I'll talk about in a minute, we had a bit of a split on case number 1, the liver patient who had virtually no interaction. There was not uniform agreement. Most of us felt that this child should not be listed for transplant on the ethics committee. But there were 1 or 2 people who thought that wasn't justifiable. We had virtually unanimous agreement that in the second case that the patient, even though the patient was nonverbal and had limited ambulatory ability, and even though there was some nervousness and hesitancy on the part of the renal teams, they were genuinely grappling with what to do and came to us for that reason, and we thought that that patient should be listed for a transplant. And everybody agreed clearly, overwhelmingly yes, on the case number 3, that that's the kind of case that should clearly be listed, just as clearly that a patient like baby K, whatever you think about whether or not it was appropriate to ventilate that patient, clearly that patient should not be given an organ through transplantation. Even Bob Veach, who helped represent the patient's mother in that case, agreed that this patient should not be a candidate for transplant. So one of the things that came out during the course of our discussions was a fundamental and very interesting set of interrelated values that clash. One is obviously justice. We have an obligation to treat patients fairly, not to discriminate against them on the basis of characteristics that are morally irrelevant. And we don't want to get into a situation where we start distributing a scarce resource like organs on the basis of how smart people are, right? That's going down a slope that nobody wants to head towards. On the other hand, and it's very clear from talking to the teams about their hesitancy in transplanting in these cases, that they're worried about stewardship. This is not just a scarce resource, but when we were first working on this, I talked to John Lantos, and he said, this is different in kind from the kinds of issues that Ben was just talking about. Because unlike generally our obligation to be good stewards of resources like funding, this is in a way almost more like a triage situation because there just are not enough organs, which means every time we give an organ to one patient, there's another concrete individual out there who's not getting this organ and would benefit from it. That's a reality about organ transplantation that I think makes it different from other kinds of scarce resources. And we can see that clearly playing a role in the anxiety that the teams feel about using organs in ways that don't really maximally make use of them to provide the most benefit possible. So when we're stuck with this sort of dilemma and this difficulty, one thing we thought would do is to make sure that if you're in trouble, that you have a lot of company. So we thought we'd get a larger number of smart people together so that if we're going to say something that's controversial or wrong, at least the blame will get spread around to a broader number of people. So we brought together a group of pediatric ethicists, transplant ethicists, the parent of a child with neurodevelopmental delay. We had representation from the Stanford liver, kidney, and heart teams. We had transplant surgeons, as well as representation from our ethics committee. We actually came to consensus on a lot of issues. First of all, everybody agreed that well-established, data-driven medical indicators associated with poor outcomes, including adherence, should be taken into account in listing decisions. So everybody thinks that that would be a reasonable thing to do. We can see that there's a paucity of some of the data we really need to be able to justify this in at least some of these cases, so we need more data. But anytime you've got some kind of a comorbidity that indicates that there's good reason for not listing, that's of course very reasonable. It's also appropriate to consider for patients the benefits and the burdens of transplantation in deciding whether to list a child. However, parental perspective on benefit should be given some privileged status, not necessarily determinative, but privileged status. All children are entitled to consideration for transplantation, for some kind of evaluation. So anytime parents want this, there should at least be an evaluation. And every decision has to be made on a case-by-case basis. Maybe the most important thing that we recommend as a process issue is that developmental assessment by a skilled specialist should always be part of the evaluation process, and that person should participate in listing decisions with the team. The one thing that came out overwhelmingly in the course of some of our considerations, both individually at our center, at our institution and within the consensus conference, the presence of the developmental specialist makes the kids come alive. On the surface, the very different scenarios I presented in case number 1 and case number 2 really don't look that different from a distance. These are both severely impaired kids who are nonverbal, non-ambulatory. They look very similar in one respect. But the developmental assessment and the person who's a specialist really makes those kids come alive. And really, you really see the kid and who they are. And it has a profound influence on the culture of the listing team to have that person be part of the decisions. And we found that this made a really big difference to the liver team, that this person was there as part of their consideration. And when the kidney teams were grappling with this and they didn't have this, they turned to the the developmental specialist for the liver team to do that for them. And it really changed the way they looked at it and made them decide, we need to have somebody like this be part of the way we make our decisions going forward. And so we would recommend that should be the case always for all teams. We agreed that there had to be some line beyond which it made no sense to list. We did, and in fact, everybody agreed that there was some point where it didn't make sense to list kids. What we didn't have consensus on where that line was. So for some people, it was a little bit higher than permanently unconsciousness. Some people thought it might be at about the level of case number 1. Some people thought it should be lower than that in permanent unconsciousness. But everybody agreed it should at least be at that level of permanently unconscious patients, that there's no benefit to those patients and they should not be listed. We also had a consensus that mild to moderate neurodevelopmental delay should not by itself ever be a contraindication for transplant. And yet it's clear that is sometimes happening. Palliative care should always be offered as an option where there is some question of the benefit-burden ratio of transplant. And again, that should be true for all patients regardless of neurodevelopmental status. We also thought it was important that there be transparency in the process of decision-making by the program. So thinking about this issue and stating what their standards are and what their process is so that it's more accessible to the community that are seeking transplants is something that's important. We also thought there should be better data kept on outcomes for these patients so that we have a better database. Right now the data is really, really impoverished. We need better data to know whether this really works. And then finally, when you do have irreconcilable conflicts, which is in a way what we're really talking about here today, when the parents want something and the team is adamantly opposed to it, there needs to be, as a matter of process, some kind of an appeal possible for the parents. And so that needs to be set up so that they can go to some kind of a body, a board, whether it's the ethics committee or some kind of a board set up that includes relevant experts, ethicists, as well as parental representatives of patients with neurodevelopmental delay, so that that board can help address that kind of conflict in cases that it arrives. Let me just thank some of the contributors to this process and to make it clear that the recommendations are my read on the results of looking at the transcripts from our meeting. They have not yet been approved by all of the people on this list who were attending the meeting and participants, and include a lot of the people in this room. And I want to especially thank the Greenwall Foundation that funded our consensus meeting and made that possible, as well as Lucile Packard Children's Hospital. Thank you very much.